Good evening and welcome to Milford Regional Medical Center. I'm Donna Boynton, the Public Relations and Community Benefits Coordinator here at Milford Regional. Tonight we are honored to have Dr. Jeffrey Dietz with us. Dr. Dietz is from New England Hand Associates on Fortune Boulevard here in Milford. Dr. Dietz graduated with honors from the University of Virginia School of Medicine. He completed an orthopedic surgery residency in Northwestern University in Chicago. He received further training in hand and upper extremity surgery at Brigham and Women's Hospital and Children's Hospital in Boston, while completing the Harvard Hand and Upper Extremity Fellowship. Dr. Dietz is board certified in orthopedic surgery and hand surgery, and tonight he's going to speak to you about carpal tunnel, tendon inflammation, arthritis, elbow tendonitis, and other painful conditions. So, Dr. Dietz.
Thank you all for coming. I appreciate it. I know it's raining out, kind of an ugly night, but I appreciate everybody coming. Again, my name is Jeff Dietz. I'm here to talk to you guys about some of the common things that myself and my two partners see in our office. Common question is, what is an upper extremity surgeon? That's the question that we got. And Donna went through some of what the qualifications that myself and some of my partners have. We are all usually orthopedic surgeons, which means that we have had about 5 years of an orthopedic surgery residency after medical school. Almost all of us have completed a fellowship training, which is about a year of upper extremity surgery, which, you know, I commonly get the question, what is an upper? What do you do? Do you just do the hand? Your group name says New England Hand Associates. And actually, myself and one of my partners do everything from the shoulder to the fingertip, and that's something that we just wanted to make sure that you knew. These are myself and my two partners, Dr. Brunelli and Dr. Juris. Some of you may know them from other times that you've seen people in our office. We have 3 offices, one in Milford, one in Framingham, and we have new offices in Concord and Westford. So we're sort of a traveling roadshow, if you will. So what do we do? Yes, we do things like this: complex trauma to the elbow, complex trauma to the shoulder, and very complex trauma to the hand. But I would say the majority of what we see in our office consists of 5 categories. So that's what our top 5 is going to go through today. Nerve entrapment syndromes are very common. Tendon inflammation disorders are very common. Thumb arthritis is very common. Dupuytren's disease and elbow tendonitis. So these are the 5 general categories that we'll be talking about today. And we'll start with probably the most common thing that we see in the office, which is nerve entrapment. Most people know this by 2 names, either carpal tunnel syndrome or cubital tunnel syndrome. We'll start with talking about carpal tunnel syndrome. So what is the carpal tunnel? The carpal tunnel is an area in your wrist that's made up of a series of bones and a ligament that sits over top of it. What runs through the carpal tunnel are some tendons that you see here, and this little yellow thing, which is the nerve. It's called the median nerve. The median nerve has 2 functions. It functions for sensation in your hand, and it functions for motor strength to the muscles in your thumb. Who cares about carpal tunnel? Well, we certainly do. There are over 500,000 cases of carpal tunnel across the United States annually, and it's about a $2 billion economic input in just the United States alone. So we care. The symptoms of carpal tunnel typically can vary to some degree, but I would say the majority of patients will say my hand is numb. And for the most part, the numbness and tingling involves the thumb, the index, the long finger, and a little bit of the ring finger. Pain is also a very common symptom. Most patients will say their pain is more prominent at night. Occasionally, this is something that can be alleviated with simple actions like wringing out your hands. That's a common thing that patients will say, and it's usually worsened with certain activities like reading or driving. The causes are carpal tunnel. I usually get this question: could this be something that comes from what I do at work? I type a lot, I'm a construction worker, and the short answer is we don't really know what causes carpal tunnel, but there's not a lot of good direct evidence to suggest that this is work-related. Most of the cases are idiopathic. We're idiots. We don't know what causes it. Occasionally, an anatomic cause like a tumor or trauma can cause carpal tunnel, or systemic causes like diabetes. When we are examining your hand, if you have carpal tunnel, we are trying to provoke the symptoms that we talked about earlier, the symptoms of numbness and tingling. And we do that by, we'll go back, tapping on your nerve to see if that irritates your nerve, putting your wrist in funny positions, and pressing on the nerve. Does this irritate the nerve in your wrist? These are sensitive tests that can help us make the diagnosis. Occasionally, if a patient has very advanced carpal tunnel syndrome, we'll see atrophy of a muscle, typically in your thumb, but most of the time we're confirming this with this test. This is called an EMG. It is what most patients know it as the needle test. And what I think is hilarious about this picture is the smile on this gentleman's face, which tells you this is before they did the test. This is not a terribly comfortable test. It's not a perfect way to evaluate the nerve, but it's really all we have. An MRI is occasionally necessary if we're suspecting a mass or a tumor or some trauma, but most of the time this is confirmed with a test called an EMG. We try lots of different splints for carpal tunnel, and people say one splint works better than the other, but really it doesn't matter. A splint for carpal tunnel is almost always the first thing that we will try. It's been proven to be very effective. The idea being that certain positions of wrist flexion and extension can provoke carpal tunnel symptoms or add pressure to the nerve, so they're working by holding your wrist in a neutral position. It doesn't matter which one you buy. One is not better than the other for carpal tunnel. And I typically recommend, some doctors will recommend full-time while you're active during the day, but I think night splinting has been proven to be the least cumbersome and the most effective. Medications, there are some patients that have tried vitamins for carpal tunnel, or there are different things that you'll read about online. Yes, they can be effective in certain instances, but there's really no clinical evidence that they're better than just a placebo. So carpal tunnel steroid injections, not that kind of steroid, but this kind of steroid can be given for carpal tunnel. There's some evidence that they can be effective, but usually for short-term pain relief. And they're most effective in patients who have very mild symptoms, so occasional numbness and tingling, and very early symptoms, symptoms that have been present less than 6 weeks. Carpal tunnel release procedure is commonly recommended for patients who are not responding to some of the earlier, easier forms of treatment, specifically the braces and the shot. Carpal tunnel release procedure, the way that myself and my two partners do this is with what's called an open carpal tunnel, or a mini open. It involves a very small incision in the palm of your hand, about 1 centimeter or 2. It's the ligament that we talked about earlier that's pressing on the nerve is divided under direct visualization. The ligament's here, and you can see the open nerve here. And we put in typically 3 or 4 sutures to close the wound. That's the traditional sort of tried and true method to release the carpal tunnel, and it's been proven to be very effective. You may have read about or heard about an endoscopic carpal tunnel release, which is available, and there are certain physicians that advocate for this. It's typically 1 or 2 incisions, one in the wrist and one down in the palm. And this instrument is an endoscope that's used to divide. It has a little knife blade on the end of the endoscope that is used to divide that same ligament. So you are putting this camera underneath and pulling the knife blade up under the transverse carpal ligament and dividing it using the camera. I think that this is a very reasonable way to do it. I think that there's always a controversy as to which one's the best, so to speak, and I don't think that there's a real consensus as to which one is the best. There certainly is, the people that advocate for endoscopic carpal tunnel release say that there's an earlier return to work. That is definitely true. That's been proven by multiple studies that patients that have an endoscopic carpal tunnel release return to work. But if your job is heavy use with your hands, like construction or heavy machinery, that type of thing, for that doesn't necessarily pertain to all occupations. So certainly if you are doing heavy use with your hands, that may be true. So the other thing that sometimes patients or sometimes physicians will say is it's a smaller incision. That's actually not accurate. The incision that we make for an open carpal tunnel is about 1 centimeter. It is placed in the palm of the hand, and the endoscopic is 2 incisions that are each about 1 centimeter. So that's not really accurate because my math is 1 + 1 is 2, but that is something that you'll hear. And the endoscopic does have a slightly higher risk of complications, especially if done by somebody who has done less than 1,000, which is a lot. It's also significantly more expensive, on the order of 4 times more expensive than an open carpal tunnel. If you're not paying for it, you probably don't care. But I think these days with higher deductibles and higher co-payments, that becomes an issue. So what to expect if you're having carpal tunnel? It's day surgery. Anesthesia can either be a local plus a strong sedation versus something called a beer block, but not that kind of beer. It's this type of beer block. It's a tourniquet cuff on the upper part of your arm with an IV on the back side of your hand with medication injected into the IV that puts your whole arm to sleep. It's called regional anesthesia. Takes about 15 minutes. There's a soft dressing on your hand for about 5 days. And like we talked about earlier, back to work kind of depends on what you do. Cubital tunnel syndrome is the next nerve entrapment syndrome that we see that's very common. It involves a different nerve. We talked about the carpal tunnel being the median nerve. This is an entrapment of the ulnar nerve. The ulnar nerve typically gets entrapped up in your elbow, on the inside of the elbow, from multiple sites of compression that involve portions of your triceps muscle or an accessory muscle that lives in your elbow. The symptoms are a little bit different. So we talked about the carpal tunnel being numbness and tingling sort of on the thumb side. This is numbness and tingling more on the pinky side of the hand. And occasionally patients that have real progressive cubital tunnel syndrome will start to see atrophy of the small muscles of the hand. Diagnosis can be confirmed on an EMG, but a negative EMG does not rule out carpal tunnel, meaning that an EMG is commonly negative in this condition, especially early on. It's more a clinical diagnosis, and certain clinical findings like prolonged periods of elbow flexion can provoke this problem. Non-operative treatment is usually recommended, especially for patients who have very mild symptoms. So splinting is an effective way to manage this. This is a splint that you'll find on Amazon that's about $60. It's worn mostly at night for cubital tunnel syndrome. You can accomplish the same thing with some with a towel and a duct tape. That's the whole idea, is preventing flexion of your elbow during prolonged periods like when you're sleeping. So that's an effective way to do it. Physical therapy can also be a very effective way. Exercises called nerve gliding exercises, which allows for the nerve to move more freely in the elbow, and just avoidance of certain things. So we know that cubital tunnel syndrome is certainly worse with patients who are in occupations or do certain things that cause a prolonged period of elbow flexion, can provoke the symptoms. So avoiding those things, scooting your chair back at your desk at work, scooting the chair back in your car, not talking on the phone for an extended periods of time to your brother, that type of thing. Operative release can be necessary for patients who are not responding. That involves simply just releasing the ulnar nerve from those sites of entrapment on the inside of the elbow. This would be an exceedingly excessive incision. Most of the time it's 1 to 2 centimeter incision on the inside of the elbow. Occasionally, for very advanced cases with muscle atrophy, transposition, which means moving the nerve, can be necessary. It's putting the nerve in a newer, healthier home. So we'll move on to some tendon inflammation. So trigger finger is easily, by a factor of probably 5 or 10, the most common problem we see in our office. So what the heck is trigger finger? This is inflammation of what's called your flexor tendon sheath. Your flexor tendons are what help you move your fingers into the palm. They are encased in a sheath, so this sheath here, and a series of pulleys that help give the tendon mechanical advantage in your hand. And right around one of the tendons in the palm of your hand, the tendon can get inflamed and irritated, and when it does so, it gets bigger. When it gets bigger, it can no longer glide effectively through these pulleys, and it gets stuck, so your finger pops and clicks open. Most of the time, patients will say the symptoms are worse when they first wake up in the morning, and in fact, sometimes patients will say, well, I need to manually unlock my finger in the morning. And it's typically very painful in the palm of the hand. This is another one of these things that we really don't know what the cause is. We do know it's more common in certain patients, specifically in diabetics, but we really, most of the time, don't have a true cause. Diabetics, if you are a diabetic, 10% of all diabetics will at some point during their life develop a trigger finger, so very common. Steroid injections is usually the first course of treatment. It's like the duct tape for orthopedic hand surgeons. It works for everything. It is 80% effective in the long term, meaning when we looked at patients at a year, about 80% of patients said they did not have a recurrence of their symptoms, slightly less effective in diabetics. And I think it's most effective in patients who have had very mild and very early symptoms, very similar to a carpal tunnel injection. Splints, in my view, are not particularly effective and they're very cumbersome. So it's usually a cortisone injection is what we'll offer you if you come into the office. When the cortisone, if you are in that 20% of patients where it doesn't work very well, trigger finger release can be an effective way to manage the problem. That's a very simple procedure. We release the pulley. So we talked about the tendon being inflamed and it's getting hung up on one of the pulleys. We can release the pulley in the palm of the hand through about a centimeter incision. It is a day procedure, just a local anesthesia, Marcaine or lidocaine like you get at the dentist. And then a soft dressing on your hand for about 5 days. Return to work, again, depends on what you do, but it's a very simple procedure. So occasionally, very occasionally, in patients with long-standing trigger, there can be an anatomic abnormality of the tendon sheath that can cause continuing triggering. There is another procedure that can be done in those very rare cases to release one of the slips of your flexor tendon. So you have two flexor tendons in your hand. One of them comes up the palm of your hand and splits. We know if we can take off one side of that tendon, it can make the gliding of the two tendons together more effective. So occasionally we'll have to do that. Maybe out of 1,000 trigger fingers, we have to do a resection of the tendon. I think most general orthopedic surgeons would attempt the original trigger finger procedure, but when you continue to trigger and have issues, you probably would be referred to a hand surgeon. I doubt there'd be a lot of general orthopedic surgeons that would do a tendon resection. Yeah. All right. Again, simple procedure, 5 in and out of the hospital in less than a half hour. DeQuervain's tendonitis. This is the most common form of tendonitis of the wrist. It usually involves the thumb side of the wrist. You're probably going to start recognizing a common theme. We don't really know what causes this. We're a bunch of ding-dongs. We haven't figured out what causes any of this. But we think that it probably has something to do with some aberrant or abnormal tendon anatomy on the thumb side of your wrist, and also some activity that you're overdoing. We see this a lot in people who are caring for children or young mothers, and it's typically as the child is starting to walk but isn't very good at it yet. So you're doing a lot of picking the child up, and that commonly causes this problem. It's much more common in women, which may be, we're not sure exactly why. It may be related to a higher incidence of this tendon abnormality. The symptoms are wrist pain, and it's usually thumb-sided wrist pain. It's usually worse with lifting objects in a certain way. So when you're bending over to lift something up, lifting with your wrists is painful, and it's usually on the thumb side. Occasionally there's some swelling in the wrist and occasionally some clicking or a popping sensation as the tendon is trying to glide through that pulley system. This maneuver would be a clinical exam, would be a physical exam finding that we would do in the office. This would provoke the symptoms on the thumb side of your wrist. So this would be an indicator that we should consider that as a diagnosis. Splints are very important, but not this splint. The thing that you notice, the difference between that splint and this splint is this splint has a thumb attachment to it. We just talked about this being a problem with your thumb tendon, so if we leave the thumb out of this brace, you can actually make this problem worse. So patients will come to my office and say, I've been wearing this brace for the last 6 weeks. I had it for my carpal tunnel and I threw it on. You can be making the problem worse if you're not wearing the right brace. So a thumb brace is a good first step. It can be very effective. And again, more orthopedic duct tape or steroid injections can be effective. 80% of patients have complete resolution within 1 year. There is a surgical release and a surgical procedure for DeQuervain's tendonitis that involves releasing the tendon, similar to what we do for the trigger finger, and that involves a small incision on the thumb side of the wrist. We have to avoid some of the important structures on the wrist, like your nerve, and then we divide and free up your tendons in your thumb. This is a straightforward procedure. It's day surgery, again, just local anesthesia. You do have to wear a splint on your wrist for about 10 days, which is the cumbersome part, but the procedure, you're in and out in about 30 minutes. Thumb arthritis. This is a very, very common problem. When I've given this talk a couple of times, this probably is the most common problem that people ask about, and that's because it is the most common site of arthritis in the upper extremity. Women are much more common than men. Not sure, again, why. And if you are a woman and you live to 75, you have about a 40 to 50% chance of developing arthritis. Most of the arthritises that we see are wear and tear arthritis, not rheumatoid. There's a common confusion about that. Rheumatoid arthritis is an inflammatory condition. What we're talking about here is osteoarthritis, which is a wear and tear type condition, just age-related wear and tear. And it typically has to do with, why is this joint so common? It has to do with the way that this joint is made up. So it's a crummy shape for the joint, and the joint is stabilized by a very weak ligament that tends to rupture over time, and that leads to the joint subluxation and wear of the cartilage. The symptoms are, as you would expect with most arthritis, which is pain at the base of the thumb and sometimes weakness related to that pain. Difficulty grasping and pinching objects, opening doors, any type of pinch is very difficult and painful. And as this progresses, you can actually start to develop these significant deformities of your thumb as the arthritis really wears down that joint, and you can even get a deformity where you have this Z deformity. The clinical exam finding is, as you would expect, it's pain, right? Examining for pain right at the base of the thumb where the joint lives. The diagnosis is based on a classification scheme, which I don't find particularly effective because I think telling somebody that has daily pain and debilitating discomfort that they only have a stage 1 doesn't really help, because it may not really guide our treatment. Where it is helpful is that it can tell me how well certain things may work. So classification system is based a 1 to 4 type classification system, with 1 being a very mild arthritis and 4 being very severe arthritis, or what we talked about before, the Z type deformity. It doesn't always correlate to patient symptoms. You can have a stage 1 but have very debilitating discomfort, and stage 4 and a very deformed thumb with very little discomfort. So it doesn't correlate. Where it's helpful is I can say, with this type of a joint that we see on the x-ray, where we really don't see a lot of wear and tear, the cartilage is fairly well maintained, the joint shows a little bit of widening, probably will respond pretty well to just splinting and cortisone injections, which we'll talk about. That one, probably not so much. That one is probably not going to be, I don't think it's a terrible idea to try a cortisone injection, but the idea that that's going to give you long-term relief is probably not reasonable. So again, we talked about splints. It doesn't really matter, hand versus a forearm based. I prefer a forearm base. We've even kind of gone down to taking this joint out and just having it immobilize the base of the thumb. I typically do not recommend this except for in a post-surgical patient. The early stage, like I said, responds very well to these braces. I usually have you wear it full time for about 3 weeks. Cortisone injection, again, is very effective. Again, just like with carpal tunnel, just like with trigger finger, it works very well for early stage disease, but not as well for patients who've had the problem for a real long time. Operative treatment, this is getting into the weeds a little bit, but I think generally the surgical treatment depends on what patients do for a living, how deformed is the joint, how old is the patient, what's their expectation going forward. Early stages may involve a simple ligament reconstruction, but I would say most patients we're recommending something called an arthroplasty. Arthroplasty, by definition, means joint replacement, but it's not like what you think about if you've had a hip or a knee replacement. We are not putting in metal and plastic. It's more of a reconstructive procedure. And the procedure involves, there's a bone missing here. That's because it's been taken out here. So it involves taking out this trapezial bone here and then reconstructing the ligament. This tendon is harvested from the forearm, and it's used to reconstruct a ligament that ruptures typically with arthritis. Once the ligament is reconstructed, we have a little leftover tendon that we use as a spacer in the joint. So this is the wrist ligament is what is a wrist flexor. We can harvest that tendon because its function is duplicated in the wrist. So by taking the tendon out, we still have other tendons that do the same thing. So we don't need that. It's sort of a spare part, so to speak. What to expect for this? This is a little bit bigger of a procedure than just having a trigger finger or a carpal tunnel release. This is still day surgery. It's usually done by what's called a nerve blockade. We put your arm completely to sleep for about 12 hours. It takes about an hour and a half to complete this procedure, though, unlike about 10 minutes. But it's still a day-type procedure. You go home the same day. I think the biggest consideration here is that there is a requirement for mobilization for about 4 to 6 weeks, followed by about 4 to 6 weeks of physical therapy. So it's a little bit more of a commitment. And that's why we always try physical therapy, braces, shots first. It is a much bigger deal than carpal tunnel, and it is painful, which is the reason why we do the nerve blockade. The nerve blockade involves an anesthesiologist. The anesthesiologist gives an injection up in the shoulder region that puts your arm to sleep for 12 hours. The first 12 hours are the most painful for most patients. That may have been your experience too. So, and I think that it's helpful for the time that's most painful. But when the block wears off, you are going to need pain medications. What I would say about the procedure is that that is a common complaint is the discomfort after the procedure and the cast. I had a patient who I did a couple weeks ago who came in with showed me on his phone a woman who had basically blogged her entire experience, which is really, I think, very interesting that that's readily accessible. Some of the same experiences you're having. If you're going to have a procedure like this, I would highly encourage you to go see what the experience looks like at every stage. She blogged it from, this is what the surgeon told me beforehand. This is what I looked like that night of the procedure. The next morning was this. This was the cast they put on me. So it's very interesting. You can get all that information and know ahead of time. As you may or may not know, once you start to develop arthritis, that means the joint is wearing down. We can't stop that process. The cortisone is not new cartilage that we're injecting in the joint. We cannot, and we don't have a way to reverse the process of arthritis. So the brace, the cortisone injection, the pills that you take by mouth are all designed to decrease the inflammation and therefore the pain from the arthritis. It's not meant to halt the progression of it or make sure that you don't need the surgery down the road. It's really meant for what you said before, just the now, treating the discomfort. No, I don't think it's not a more difficult procedure if you did it in 5 years. This is, if anyone's ever had a hip or a knee replacement, most hip or knee surgeons the way they assess your need for surgery is, the question is, can you still handle the medications? Are you still able to walk up a flight of stairs? Are you just tired of this? And that's the question. And what I say to most patients is, most patients will tell me when they need this surgery. I don't tell them. because the procedure, whether it's stage 4 or stage 2, is the same operation. It's not more difficult stage 2 versus stage 4. One thing I will say about that is, like a nip, if you've had a knee or a hip replacement, you are not happy day 1. You're not happy at day 3. You are miserable for weeks. Where you are happy is 3 to 6 months. You're very happy that you did it. It's a game changer. It's a life changer. And I think that's similar to this. This is a commitment. You have to commit to this operation that it's not going to be better tomorrow, like a trigger finger or carpal tunnel release. This is a commitment. There is no evidence to suggest that repeat cortisone injections speed the process along. I have one patient who has a severe cardiac problem, and she comes in like clockwork on her birthday every year for the last 11 years. And so the point I make with cortisone injections is it's silly to repeat if it's not working, but I don't think that the dose in this area is so harmful to the soft tissue structures around it that I mind repeating it as long as it's working. The definition of insanity is to keep doing the same thing and expect a different result. So I think at some point you have to say, I would say generally cortisone injections work less well each time you give them. They work sort of in a linear way. They work half as well the next time. So Dupuytren's disease. So Dupuytren's disease is an abnormal formation of scar tissue in the palm of the hand. So this is a more advanced case, but most Dupuytren's disease will start with the pitting of the skin and these nodules that start to form in the palm of the hand. Occasionally, as this progresses, it starts to develop a flexion deformity of the finger. It pulls the finger into the palm of the hand. You cannot physically extend it even if you wanted to. What causes this? We don't know. Again, it's an abnormal proliferation of certain types of cells that normally exist in the palm of your hand. It's not cancer, but it's like cancer in the sense that these cells are normal cells that exist there. They're just not working effectively. It is idiopathic. We don't know what causes it, but there is a link to certain conditions like alcoholism, diabetes, HIV. This does not mean that you're an alcoholic or you have HIV if you have this problem. It just tends to be a link. It is not work-related. It has not been proven to be trauma-related. The only thing it's been proven to be really related to is people of Northern European descent. So they call it Viking disease in some cases. So, but that isn't always the case. Much more common in men, much more common in men over the age of 40. So it's not usually painful. It usually causes these nodules in the pits and again the cords. We typically do not need to do a lot about it when it's at this stage. When it's just a nodule, it doesn't usually affect function. We tend to consider treatments for this when these nodules start to affect function, and your function is affected when the fingers are pulled into the palm of the hand. Steroid injections are not effective. They may give you relief if you're in the early stages. Some patients will have a little bit of itching and pain in the early stages, but it's not been effective to halt the progression of this. Most of the patients that I see will come to me for a nodule or a small cord. That does not mean your finger is going to end up like this. In fact, most patients come and they have a nodule that never progresses into one of these cords. We talked about other forms of non-operative treatment. There is a new it's not necessarily new anymore. It was FDA approved in 2008. It's called Xiaflex. It is an enzyme, so it's a chemical lysis of these cords. So this enzyme is very specific for the collagen fibers in the cord. So it starts to eat away over the course of 48 hours at that cord and weaken it. So we see you, we inject the medication, and we pop the cord open 2 days later because it's been weakened. It's non-operative, but it does have some side effects. The hand looks like a Ronald McDonald hand. After a couple of days, there's significant swelling, which is sometimes unexpected by patients. It's and one of if you look up Dupuytren's, the first thing that will come up on the internet is Xiaflex, this medication. They poured in tons of money into research and development of this product, and they're really pushing this product hard. And I do believe it works in some patients, but they don't tell you that there are some side effects, and they don't tell you it's really expensive. It's about $3,000 per injection. So the way that they market this medication is the less expensive, less invasive way to treat Dupuytren's. The average number of injections that are necessary for a Dupuytren's cord is 1.4. So 40% of patients will require 2 injections, so $6,000. The average surgical cost that they calculated from anesthesia costs and surgeon costs and whatnot was about $5,900. So 40% of those cases, it's not going to be accurate. The evidence is okay, but it's short term. It's 10 years, right? So we have evidence with surgical release of Dupuytren's, which is here. It looks pretty gruesome, but sorry. But the surgical release of the Dupuytren's, we have excellent long-term data. So it's a little bit unfair to compare surgical release to XIAFLEX, which is what commonly we're having to do. But generally, I would feel that most patients who have this situation here, where the contracture involves only this knuckle, I think that's a great Dupuytren's case. Another great, XIAFLEX case. The great XIAFLEX case is a cord that's sticking way up out of the skin that I can easily get the needle in perfect location. For ones that don't have much skin elevation, or when this knuckle is involved, we usually recommend surgery. So it kind of depends on the case. XIAFLEX is not the end-all be-all for this treatment. Surgery is zigzag incisions and simply just taking out the diseased cord. It involves occasionally a skin graft when you have the real severe cases where the finger is stuck in the palm of the hand, but most of the time not. It's day surgery, general anesthesia. Time is somewhat variable depending on the degree of severity of your problem. Splinting post-op and typically pretty significant physical therapy for at least about 6 to 8 weeks. Elbow tendonitis. This is, if you're looking at top 3 in our office, this is probably 2 behind trigger finger. I think that most people at some point will develop tendonitis in their elbow at some point. Tendonitis of the elbow is, this is, in my view, a design flaw here. These muscles in your forearm all insert on this little bony protuberance on the side of your elbow. These muscles generate a significant amount of force, and they all do so through this common, tiny, wispy little tendon. So injuries and overuse type injuries are very common in that area. Typically involves tiny little micro tears on the tendon that try to heal and rupture. What do we know about this? It is a very common problem. Bad news is it hurts really bad. The good news is that it goes away. It tends to go away on its own. A recent study was just published that showed that if we looked at patients at a year, 90% of those patients would be better at a year. And it didn't matter what we did to them, braces or cortisone shots, 90% of patients got better at a year. Bad news is it's a stinky problem to have, but it goes away. It's usually pain with extension or lifting a bag off the ground with a straight or an extended wrist. MRIs can sometimes be indicated, although really not necessary. You can make this diagnosis clinically and just based on numbers. It's the most common problem we see in the office. There are lots of forms of non-operative treatment that people try for this. This is called a tennis elbow strap or counterforce brace, and it works like a guitar capo in the sense that it's sort of tricking there's no like a capo here, there's no vibration of these strings above on the strum board above the capo. There's no vibration of the muscle above this strap here. And so the area that's inflamed gets a chance to rest. It works okay. It doesn't work for every patient. Physical therapy is extremely effective for this, but is a time commitment to be fair, and can be expensive if you have a large deductible. Cortisone injections are effective, but in the studies that we've done, they're really not a lot more effective over placebo. but anecdotally, I find patients get pretty good pain relief. I usually reserve it for patients who've had symptoms for a long period of time. Botox, some people do it, although you probably end up looking like her if you have too many Botox injections. Again, Botox has not been more effective over placebo. All these things have been tried. Fine needle aspiration, or platelet-rich plasma injections, Botox, cortisone injections, and there really isn't a lot of large study evidence to suggest that it's a lot better than just placebo and physical therapy. Time is really the answer for tennis elbow. We said 90% are better, so 10% are not going to get better. So what do we do with the small portion of patients that still have pain after about a year? Open debridement or tennis elbow surgery can be an effective way to manage this, but it is not an end-all be-all. 80% effective in the long term, which 85% effective means that 15% of patients are going to go through this surgery and not really get a lot of pain relief, which to me is not a great procedure. So to be fair, it's not great. That number is a little bit skewed by your workman's comp patients, but yeah, it's probably about 90% effective in non-workman's comp patients. The procedure is a small incision. We debride the devitalized tissue. It takes about an hour or so. It's outpatient surgery, usually general anesthesia, and then about 6 weeks of physical therapy. Occasionally, patients will do that arthroscopically. So the common misconception, I see a lot of patients at month 6, and it's usually referred from somebody that says, you need an MRI. You have to get an MRI here. It's been going on too long. This should be better. And the answer to that is, I'm happy to get the MRI, but I know exactly what it's going to say. It's going to say there's degeneration of the common extensor tendon, or in your case for the inside of the elbow, the common flexor tendon as it inserts in the medial epicondyle. You almost can read the report of the MRI before you even see it, because that's what it says in every case, and it isn't abnormal to have symptoms, unfortunately, for 6 months or longer. When would you consider an MRI? I think when the symptoms aren't classic tennis elbow symptoms, maybe the pain's a little bit more farther down the forearm, maybe it's associated with some numbness and tingling. That's when I think a little bit more investigation, but classic tennis elbow pain probably does not need an MRI, and it's because of that degeneration of the tendon. All right, thank you for coming.